We hope you enjoy this video on what does COVID-19 mean for inpatient diabetes. Please share your thoughts in the comments and subscribe to make sure you don't miss any new content that we upload. I am now pleased to introduce you to your webinar leader, Professor Gerry Rayman.
Thank you very much for the introduction, Hope. This is really going to be quite informal. I'm going to go through a little bit of the background of diabetes and COVID, not into any great detail in terms of the pathophysiology, but information which I think we'll all find useful. And then I'm going to take you through some of the work that a group of us have been doing around guidance for care of people with diabetes as inpatients, because I think that's become relatively complex, and certainly the number of people with COVID who are developing diabetes or people with diabetes who have COVID is actually quite a significant number in the hospital. And this can sometimes be tricky to manage. So what are the implications for inpatient diabetes care for patients with COVID? Is going to be the introduction, and then I'm going to go through some of the guidance that we've produced. There's no evidence at the moment to suggest that people with diabetes are at greater risk of being infected by COVID. But indeed, they have a significantly greater mortality. And you've probably seen the recent documents from NHS England, which demonstrated that, certainly from the UK database, from the National Diabetes Audit, a third of the deaths in hospital from COVID were in people with diabetes. And overall, 31% who died had type 2 diabetes, and obviously a much smaller proportion with type 1 diabetes, 1.5%. That data from Jonathan Balabji, Bob Young, and Partha Kar also adjusted for age, sex, deprivation, and ethnicity, and showed that the relative risk of dying from COVID with type 1 diabetes was 3.5-fold increase, and for type 2 diabetes was doubled. This is quite an important slide. That sounds quite alarming, but it is very much related to age. The black line is the general population. The blue line is the type 2 patients, and the red line, type 1 diabetic patients. And you can see for all populations, clearly age is an important factor, which is something we've already known. But I think one of the important things here is to see that under the age of 40, under the age of 50, the increased risk is quite small compared to over the age of 80 in all populations. The numbers under the age of 40 with type 1 diabetes who died were too small to actually be statistically analyzed, so they were removed from that particular graph. But the important thing to say is that there were no deaths under the age of 22 and very few deaths under the age of 40. So for the majority of our younger type 1 diabetic patients, I don't think the alarmist figure of 3.5% increase, 3.5 times increase should be highlighted. I don't know if you can see this. It was a pretty poor slide in the publication, but this just again shows you this is the general population, and this is the odds ratio, and you can see under the age of 40 up here compared to over the age of 80, very much like what we saw in the previous figure. You can see that males, it's about a doubling risk of dying compared to females, and this is deprivation, and you can see as you go up the deprivation scale, the greater the risk of dying. And again, something that we now know, but was obvious really when you looked at some of the photographs of the people who died, particularly amongst healthcare professionals. You can see those in the Black ethnic minority group have a significantly increased risk. And then down at the bottom here is type 1 and type 2 diabetes. And I've already given you these figures, 3.5 and 2-fold increase. I think what's really interesting is that the risk of dying appears to be associated with preceding glycemic control. Again, as I said, this is taken from the NDA data. So this was HbA1c's, the most recent one that they could extract from the GP databases. And you can see that the higher the HbA1c for both type 1 and type 2 diabetes, the greater the risk. This has a little bit of a U-shaped curve, and you can imagine people with quite low HbA1cs may be frail patients or patients who are more at risk of going hypoglycemic. What is interesting is some of the data which has come from China. So that's preceding glycemic control. This is glycemic control within the hospital, and they found that those with persistent hyperglycemia had a 7-fold risk of dying. Now, what it doesn't say, these patients may have been preceded, maybe the more difficult to control patients. It doesn't necessarily say that control in the hospital is a cause of dying. It may be preceding hyperglycemia, and if you had an HbA1c which was high prior to coming in, that you had diabetes which was more difficult to control in the hospital. But nevertheless, I think it would suggest that good glycemic control in the hospital may be important. So this is the group who came together to produce the guidance documents, and it has been really quite a well-established group now. We've now produced, I think, 5 or 6 documents, which I think have been helpful, and they are up on the ABCD and diabetes websites, and have had a number of hits, getting into now nearly 1,000. The first set of documents that we produced were around maintaining diabetes services. And so many of you will undoubtedly have seen disruption within your diabetes services. Within some hospitals, all the nurses, including the inpatient nurses, were called to the front line and were no longer undertaking either routine diabetes care, but importantly, some of them weren't even undertaking support of patients with diabetes in hospital. And so in response to that, we felt that we needed a document, a position statement, which has come out from ABCD and Diabetes UK on how you should structure your services to deliver, one, a skeleton service to the community to make sure that we prevent patients coming in, and also that we support them on discharge. So that's your skeleton service, and then an acute service for those on the wards. And I think this has been well received, and I certainly know of a number of trusts who've fed back and said this document has been really helpful in helping them to retain a diabetes service fit for the current situation. The next set of documents relate to management in hospital. So what we do know, and we've heard this from around the country, that a number of patients are coming in with diabetic ketoacidosis, many of whom have not had diabetic ketoacidosis before, and including patients with type 2 diabetes developing ketoacidosis. What we do know is that the virus appears to increase the risk of DKA by causing severe insulin resistance and also impaired insulin secretion. The mechanisms behind this is not entirely certain, but certainly from work on SARS, previous SARS infections, it's been shown that the virus does impair beta cell function, and it also increases significantly insulin resistance. And indeed, this has been the experience in Italy and in London, and indeed now around the world, that some patients are needing several hundred units of insulin to control their diabetes. So really, in summary there, the COVID infection can precipitate DKA in anyone. So those not known to have diabetes, if it impairs beta cell function and increases insulin resistance, it may precipitate, for the first presentation, in diabetic ketoacidosis. If you have type 1 diabetes, again, because of the insulin resistance, it may precipitate diabetic ketoacidosis, and indeed just the infection in type 1 diabetes precipitating DKA. And for people with type 2 diabetes, again, because it's knocking off beta cell function, it may precipitate DKA, and the risk would be even greater in those on an SGLT2 inhibitor. So one of the most important messages in the first document that we've produced is for diabetes at the front door. So the important message is to consider DKA in anyone who's breathless. The knee-jerk reaction for someone coming into the emergency department with breathlessness is to think of COVID. Well, we would like people to also think of the possibility of DKA, even if they've never had diabetes before. So these are the documents, and I'm going to start with the front door document, which looks like this. And it's a simple flow chart in the document. So again, breathlessness could be metabolic acidosis. Ensure all new patients are evaluated for diabetes. So measure glucose in all admissions. And if they're known to have diabetes, or if you find their blood glucose level to be above 12, then you should check for ketones. For people known to have diabetes, we recommend stopping the SGLT2 inhibitors, and the reason for that is fairly obvious, because that on its own can precipitate DKA. Stop metformin in all patients, but on review, once you've got the lactate back and the renal function and you know their hypoxic status, you may consider restarting it, and then continue ACE inhibitors, ARBs, and anti-inflammatories, depending on the safety in that individual patient. The next step is really to manage hypoglycemia according to your usual guidelines in the hospital. And if you find a high blood glucose, then obviously determine whether or not they've got DKA. And the document this is not for us diabetologists, it's very much for the emergency staff, the definitions of DKA, and follow the usual guidelines, which would be the JBDS guidelines on DKA, but I'll review that in a second when we come to talk about DKA in more detail. And then for them to consider other reasons why the patients might be hypoglycemic, such as sepsis or missed insulin or a problem with their insulin pump. And again, guidance for those at the front door: what are blood ketone levels at which you would intervene, and that's all listed here. Guidance to continue basal insulin if they are on insulin already. And for patients who are using wearable technologies, pumps, and continuous glucose monitoring systems, some guidance here. particularly if the patient is unable to manage their pump. How do you convert from pumps to subcutaneous insulin? And there's some guidance given here. And then finally, making sure that they check the feet on admission, because that might be the source of your sepsis. So that was the first document, and as I say, it's been very well received. The second document is managing inpatient hyperglycemia. Now, this I think is quite relevant because in view of that Chinese data, we should aim to keep the blood sugars under 10, but obviously avoid hypoglycemia. So the intervention here is to start treating at a blood glucose above 12. I mean, you obviously wouldn't use this for DKA. And for people who are COVID positive and proving to be severely insulin resistant, such as the patients on ITU, I think this guidance would not work. You'd need to be considering using intravenous insulin infusions. So what have we recommended? So if the glucose is above 12 and you need a corrective dose, we should be using a rapid-acting analog. Your target is 6 to 10, but up to 12 is fine. Now 6 people may think is relatively high, but we particularly wanted to avoid hypoglycemia. And remembering that these patients, if they're on the COVID ward, may not be attended that frequently, so hypoglycemia could be a risk. The insulin doses are given here in 3 panels and 3 methodologies for calculating the insulin dose. The first, if you know the patient's correction ratio, so these are the Daphne patients, for example, a patient who 1 unit drops them by 4 millimoles per mole, this is where you would intervene at 12 with 1 unit, which would drop them 4, and so on. If, on the other hand, the patient is not a Daphne trained patient and you don't know their correction dose, then you would take their total daily dose of insulin, and so you'd use this column for less than 50 units. 50 to 100 would be this column, and over 100 this column. If they've not been on insulin or you don't know their total daily dose, then you'd base it on weight, less than 50 kilograms, 50 to 100 kilograms, and 100 kilograms. So this differs from most of the stat doses of insulin that we use in the hospital. Often we don't intervene until about 17, and then we'd slug the patient with a big dose of Nova Rapid or Atrapid, which risks hypoglycemia. So this is much more gentle, but it begins earlier so that we hopefully won't get up to 17 and we won't go yo-yoing from 17 down to less than 4 and up. This has now been introduced by many of the colleagues who were involved in that writing group, and they found it very successful. We would recommend that if you've had to give more than 2 correction doses in a 24-hour period, that you would consider then adding in a basal insulin, and these are the various basal insulins that you could use, and we've given a dose per kilogram. Obviously, if they're already on a long-acting insulin, you continue to use it and titrate it. There's also a very useful titration table given here. So this is for people on a once daily or twice daily basal insulin. This one would obviously be titrated on before the insulin doses, the breakfast levels, and this one would be titrated on morning and evening blood glucose values. And then finally, recommending people look out for when things are improving, they may need to reduce these basal rates. And particularly people who are reducing steroids, or stopping enteral feeding. So that was a hyperglycemic document. The next document relates to DKA, and this is the use of subcutaneous insulin to treat DKA. Now, we were requested this by a number of intensive care colleagues because at the time, and particularly in London, there was great anxiety of the fact that they were having to use infusion pumps, not only for insulin, but also for inotropes and nitrates, which meant that potentially they would run out of pumps. And indeed, in some places, they were running out of 50 ml syringes. Fortunately, I don't think this is needed to be used in the UK. However, it has been well received by people in the third world who may have limited resources. So it's based on some of the old-fashioned regimes of treating DKA with subcutaneous insulin. And what we've done here is converted a regime which has been used by UMPRES, and I'll come to that in a second. The important thing, there's certain groups that you shouldn't be using this in. So for example, if the mixed DKA and HHS, that's more complex and this regime shouldn't be used. And if there's very severe metabolic derangement, you really should be using an intravenous pump. But for the milder DKA, subcutaneous insulin works very well. And indeed, in some units around the country, they're using subcutaneous insulin in children. The aims of treatment are given here, and the treatment targets are also given. So I'm sorry that you may not be able to see this very well, but the first bit in terms of fluid replacement is quite important. You know that COVID is associated with lung leak, so fluid overload in the pulmonary area. So if it's common or garden DKA and not COVID related, then the DKA treatment, the fluid replacement treatment here is based on the JBDS guidelines. If, however, there's a concern about fluid leak from the lungs, there's a far more cautious replacement given here, and that's really quite restricted, but you need to review that frequently and certainly review it in the light of possible AKI. So here's the subcutaneous regime. It's based on 4-hourly doses of rapid-acting insulin. The UMPRES regime is 2-hourly, and some other regimes are 1 hour. We have gone for a 4-hour regime because of the possibility that patients, you don't want to have frequent contact with the patient with COVID, and getting in and out of PP is quite a palaver. So we've used the same doses overall, but 4-hourly. So a 2-hourly dose would be doubled up and be given 4-hourly. And the initial dose is 0.4 units per kilogram every 4 hours, reducing as necessary when the blood sugar falls below 14. Potassium replacement is uncertain in COVID, so that needs to be regularly checked. And indeed, we need to make sure that we're monitoring the glucose, the ketones, and fluid balance is going to be a really important aspect of the care of these patients, as well as the oxygen sats. We always recommend giving the basal insulin if they're already on a basal insulin, or starting a basal insulin, and a number of regimes are given here dependent on whether or not they have been on a basal insulin or it's a pump user that you're converting to basal insulin. So those are the two treatment regimes. This guidance here is supporting safe discharge and preventing readmissions. Now, one of the curious things about COVID is that, as I said, you may need several hundred units of insulin, but once the patient starts to get better, the insulin dose can fall quite rapidly, and some patients indeed come off insulin altogether. So although the virus seems to produce beta cell dysfunction, there can be recovery. So you don't want to be sending patients out on a big dose of insulin. There needs to be definite guided follow-up of these patients. And there are various clinical scenarios of different types of patients, which, for example, the patient unable to self-administer, the patient that needs temporary supervision, and those who are quite capable. And the guidance here, I think, is quite helpful. And then what to make sure that patient goes home on so that nothing is forgotten. Also guidance on what to do with the other medications. And then finally, which we're just completing at the moment, is a leaflet for patients, which goes through all the questions that they should be asking the healthcare professional about before they are discharged. So in summary, we would recommend that all admissions, we should exclude diabetes. If they're known to have diabetes, or if they're newly hyperglycemic, exclude DKA by ketone testing. Always think about DKA if the patient's breathless. Atypical presentations are not uncommon, a mixture of DKA and HHS. COVID-19 patients are often very insulin resistant, and on recovery, the requirement for insulin may fall suddenly. Discharge follow-up is necessary as hypoglycemia can occur, and indeed some patients do rebound into DKA. So these guidance documents are available on the ABCD and Diabetes websites, and these slides will be made available to you, and here are the website accesses. So thank you very much. I'm quite happy to take questions.
Hi, Gerry. Thank you. There was lots of really interesting resources shared there, so I'm sure people will be really keen to go and have a look and refer back to them. So the first question that we've had in is, why is there a bigger risk with type 1 diabetes?
I don't really know the answer to that, but I think the possibilities are type 1 diabetes is more difficult to control. The mean HbA1c for type 1 diabetes in the type 1 diabetes population from the NDA is clearly higher than the type 2 diabetes patients. Remember, the majority of people with type 2 diabetes who are seeing their GPs will have HbA1cs around 6.5 and 7. Whereas if you go into our diabetes clinics with the type 1 diabetics, the mean up for those patients is in the region of 8%.
Okay, that's great, thank you. Someone has asked, would you consider face-to-face appointments for diabetic patients?
Yeah, so the last slide, and I don't, for some reason, it's, there we go. We do have face-to-face appointments here. We've sectioned off the diabetes center so that we can see patients face-to-face and shielded. But we're not doing it as a routine. We are doing nearly everything as either consultations, telephone consultations, or video consultations, and they're working very well. We use Attend Anywhere, and we use System 1, so we can see their notes on one side, and we can see them on the other side, and we can also link in to LibreView or into the DiaSend. And we've got that set up. It's really working very well. So we're almost back to clearing our backload of patients by doing this. I'll just put all those up here. So these are the services we're running. The only thing that we're not running is structured education.
Okay, wonderful. Someone's written in the chat that the mean age of death in type 1 is 73 years old,
Yeah.
and most of them have had the condition for decades and multiple comorbidities as well.
Yeah, absolutely.
Yeah. So the next question, has there been any national picture yet on how many trusts inpatient diabetes teams have been disrupted or disbanded during the COVID period so far?
No. So we're actually going to do a questionnaire. So we're doing some, initially we're just doing some open discussions with people to find out what their experience has been. And from that open discussion, we will then put together a questionnaire which we hope to circulate around to all trusts to find out the impact of COVID on diabetes services.
Okay, wonderful. So next question, what should happen to eye screening and eye screening services in this time?
Right, so eye screening, certainly for us, we've started up eye screening again for those who we know have at-risk eyes and the pregnant, but it is quite limited. And again, it's in the diabetes center, and it's, as I said, the diabetes center is now sectioned off so that that can be done very safely.
Okay, wonderful. Someone else has asked, what are the guidelines or recommendations for shielding diabetics, both type 1 and type 2?
Well, that's interesting. I think certainly if they're elderly patients, then most certainly that should be the case. The younger patients, I think, as I mentioned to you, certainly under the age of 40, the risks for them are really quite small. And I think it has to be done on an individual basis.
Absolutely. Do you recommend that patients with type 2 diabetes should come off SGLT2 inhibitors in primary care?
The answer to that is no. We have taken off all our type 1 patients because the risk for decay in them is much greater. For type 2, if they've established on the SGLT2s and providing they are educated in the prevention of decay, I think it's quite safe for them to continue on it.
Perfect. We've got another SGLT2 question. Someone's asked, do we need to stop or withhold SGLT2 in COVID positive patients?
Yes.
Simple answer. Yeah. Do you know why COVID-19 causes insulin resistance?
Yeah. No. No is the answer. I mean, there's lots of potential theories, and I can't really go into it in any great detail, but the answer is not at the moment. I mean, clearly there are a lot of metabolic disturbances that occur with COVID.
Absolutely.
And I've got a pet theory that you know, because of the disruption of the vasculature and the microvasculature, perhaps that in itself may be involved.
So next question, is there an opportunity to increase technology interventions to allow remote consultations?
Yeah, so definitely, and there is some consideration to make the Freestyle Libre available for people going out of hospital. So that, as I've said, you may need to down titrate the insulin quite rapidly, and it can be quite tricky. So the Freestyle Libre may well be useful in these circumstances.
Okay, that's really helpful. Thank you. Next question is, what is your opinion on patients with diabetes shielding if they have a high HbA1c?
Well, they should be encouraged clearly to try and improve their HbA1c. I think that's the bottom line. Yeah, and just look after their general health.
Okay, that's great. We've got a couple more questions. One that's just come into the chat is, where can we find guidelines for starting diabetes services?
For starting diabetes services, yeah, for restarting them, or sorry.
It says starting, but yes, they mean restarting.
Right, so there's some work going on that at the moment. If they go onto the NHS England website, there are some outline recommendations, but ABCD is looking at providing useful guidelines on restarting services.
Okay, that's really
and that's going to be fast tracked, so you will get that fairly soon.
Oh, thank you. So, would you advise patients to still attend for their annual blood test for their annual review, or should they hold off during the pandemic?
I think it depends on how well the blood tests are set up. So some general practices have got good separation, shielding for people having blood tests. So if you have access to that, that's fine. We are actually, what we're doing is we're getting patients to drive up to the diabetes centre, and they can make their way into our small path lab in the diabetes centre if we need to do their blood tests, and we're not doing it in everyone, and they are well shielded to have their blood test done. If you need an HbA1c, we ask them to sit in their car, they ring into the diabetes centre, the lab assistant goes out, does the finger prick test with the window car wound down, and then the HbA1c can be done. And for those who are coming up for venipuncture, again, the same system exists, that they ring to say that they've attended, and then they can come in without facing any other patients or any other staff.
That's really interesting, thank you. I know that in Sheffield, they're doing a kind of drive-through blood testing as well, so there's lots of different ways to try and get around that.
We're just about to set up a system. I've done the background work on it, and I just need to finalize it. So we have been using STARS test tubes to patients can do their capillary finger pricks at home, fill the tube, and send it in, and we can get an HbA1c done that way. But it's a little bit fiddly, and I'm looking at other blood test tubes, because it's not that easy to fill the STARS test tubes, and sometimes it's difficult to the problem with that is that the plasma and the red cells separate, and then you get a high hematocrit error on the HbA1c machines. But we've found a way that we think we can deal with that.
That's great. So next question is, when are you looking to start structured education again, and do you think this needs to change in light of COVID?
Yeah, I don't know when we're going to start it again, but certainly we're using some of the online facilities for structured education. And I think I think that's going to happen over the next, that'll have to continue for the next 6 months.
Okay. Thank you. Someone's asked about preconception clinics, and what would you advise against planning pregnancy for diabetes patients during this time?
I think that's a difficult question. We can do preconception clinics by video conferencing. That's not a problem. I don't know whether people should be getting pregnant over this period. I really don't know the answer to that.
Yeah, it's a difficult question.
And that's for people even without diabetes.
Yeah, absolutely. So next question is, this is a comment for high insulin resistance in COVID. They think it's possibly because of the high cytokine storm between high stress hormones.
Yep, agreed.
So someone's written, there seems to be more evidence coming out in relation to COVID significant vasculogenic changes, which puts people with metabolic conditions such as diabetes at higher risk of mortality. With a potential second peak coming, should the government consider putting diabetes as a shielding condition?
And again, I think yes, but I think this will relate to age again. I think the age is the key thing for me. Good.
And then someone has asked, when do you ask diabetes patients to see you physically?
When do I ask diabetes patients to
See you physically?
Well, I think the annual review would need a physical examination, so blood pressure and checking feet. So as I mentioned to you, we can do the HbA1c, we can do those interim appointments where you just need an HbA1c, the kind of 6-monthly appointment, that's fine. We patients who you're troubleshooting, so they've got poor diabetes control, then we can do that, you know, twice a month or whatever, by video consultation or telephone. That's fine. I've had 2 patients today who are a bit metabolically unstable, so I've arranged to follow those up. That's fine. I don't need to see them physically. They're all linked their meters into the system, so I can see what's going on and we can have a useful discussion. For those in whom you're worried about things like hypertension or their feet and so on, I think you do need to see them. And we have 2 rooms in the diabetes center which are face-to-face shielded rooms, and they're set up to be able to do that. The number of patients you need to do that for is, at this moment, is quite small, but when we, and this is where the documents from ABCD will be useful. There will be recommendations on who definitely needs to be seen physically, that would be the red group, an amber group potentially need a face-to-face, and then the green group would be those who generally very well controlled, haven't got any complications, you wouldn't need to see them physically, and they can go to 18 months, for example. So I think it's going to depend on the patients. Now, the difficulty here is you need a good database to be able to go through all your patients and extract those using these criteria to be able to then separate your patients into the red, amber, and green groups. For us, some of us who are using System 1, that's terrific, and those who haven't got diabetes databases for their specialist services, they may be able to get the information from GP databases.
Do you have any advice for people who are looking to set up a database, diabetes database, or would you just say go to the GP database first?
I think to set up a database, it takes a while. So it takes about a year to get everyone on. You might be able to do it by extracting it from the GP databases and then putting it into your database, but you'll need to have a list of all your patients and their NHS numbers, and then use that to extract it from the GP database.
Okay, that's great, thank you. So we've got, looks like one more question at the moment, unless we have any that haven't been sent in just yet. So the question is, should GPs consider testing for COVID-19 in all patients with unexplained deterioration in glycemic control?
I don't really know the answer to that. There are lots of reasons why their diabetes control could deteriorate, and I think that's the first thing to understand. There may be a pretty obvious reason, but I don't think those who are unwell with COVID would necessarily, those who are well and asymptomatic with COVID would have unstable diabetes control.
Okay, that's great, thank you. Oh, we've just seen another question come in. Is there NHS or Public Health England data that you showed being published yet?
It hasn't been peer reviewed yet. It's sitting with the Lancet at the moment. But if you go to the NHS England website, you would be able to access exactly what I showed just now.
Okay, well, that's great. Thank you so much, Gerry. As I said earlier, you've shared some really helpful resources, so I'm sure people will find them very useful.